Is the raise of hands? Very few. Anybody wants to convert to CR? Okay, so this talk is only for few people in the audience. Can I have my slides there? But my slides. This. So, as we saw that the beautiful talk by Dr. A.S. Prasad that the knee has to be balanced perfectly. That's very, very important to balance the knee properly. Whether you want a CR knee or a PS knee, doesn't matter, a middle pivot knee doesn't matter. But if you want to learn CR knee, Dilpan's very rightly said that what all you can do to balance and flexion extension. Now, certain things are important for a CR knee. One thing is to begin with, it's a single plane deformity, then you can try a CR knee, a dual plane deformity. It will take some time because you need to get confidence to release the PCL from the femur and tibia, and then you can balance those knees, because once the ACL is gone, the PCL is actually contracted, and that's where the challenge comes. So it's a dual plane deformity like a flexion varus, and probably don't attempt it there to begin with. With experience, you can definitely do that, but with the single plane deformity, you can easily do that. Now, very important thing in a CR knee, we have all seen that the rollback and the slope. By no computer, no robot, you can decide what slope is the ideal for that particular patient. So that's why I use an IM jig for the tibia cut. So as you can see here, we make an Agagi line there and the center point of the tibia. Then you put an IM rod inside and then use the jig. So by putting an IM jig inside for the tibial cut, what two things you decide here? The slope of the tibia is decided by the native tibia. What is the native slope of the tibia? We have given that same slope and same varus valgus, whatever the native for the tibia is. So it's not that giving some degree of varus or valgus, it's the native slope, which is maybe 5 degrees, 6 degrees, 7 degrees, or maybe 7.8 degrees, we don't know. So we are giving the same slope of the tibia as the native tibia is. That's the key factor, because your CR is going to build up on the tibia. And that's why you can get a very good slope. As you can see here, there's a perfect aligned slope if you do a IM jig for the tibia cut. That's the first tip. Now, posterior osteophytes, when you remove in the CR knee, is actually they open up the flexion gap rather than extension gap more. They will open up the flexion gap because when the PCL will restrict the extension. So once you flex the knee, the posterior osteophyte, they will hit on the poly and they will give you a feeling that your knee is tight. So removing those posterior osteophytes actually opens up your flexion gap. Now, very important osteophyte, as we see in the Oxford knee surgery, that you have to do a notchplasty. Same way, on the posterior part of the medial condyle, the PCL gets attached there, and there's a small osteophyte which actually tends up the PCL. If you open that, your tightening on the medial side will go away. So that's another tip. Instead of releasing, what you do is you remove this small piece of osteophyte, and that's very, very important to balance the knee in flexion, as you can see there. So PCL tightening has to be released by moving that posterior osteophytes. A well-balanced gap is very, very important. As you've seen, a little bit of opening in the flexion is fine. In extension, usually it's a rock-solid extension. Now, checking the stability, there are different tricks and tips how to check the stability of a CR knee. So what I do is I take the heel in full external rotation and then do the flexion. And then you take the knee in full internal rotation and do the flexion. If in both the range, the poly is not popping out, that means your knee is absolutely stable. There won't be any mid-flexion stability and need not to release anything. The range will be full. So that's how I check the stability for a CR knee. Now, sometimes a rotationally unstable knee, which dashboard technique you can use, but I usually don't like, because this kind of instability will not work, and probably I will switch to a PS knee in these patients. So just to take care of this, because once you do that rotational range of motion check, this will come out and then you convert to a higher constraint knee. Now, looking for the rollback is also very, very important. As you can see here in this video, so in full extension, this line is coming at this point. But the moment you flex the knee, it goes into the tibia goes into internal rotation because the knee is hanging. So in flexion, it's in line with around the whole of the pec, and in extension, it's at the lateral part of the trochlea. So that rollback is very, very important to see once you complete your trialing. And if you see from the top, the lateral part of the tibia plateau is more visible than the medial part. That means there's a definite rollback is happening on the lateral side. That's also an important trick to see when you are planning for CR knee. The other thing is a full correction on table, because PCL is there on the back side, will not allow any kind of stretching later on. So it has to be fully corrected on table, usually without any kind of extra pressure, and then it should be fully corrected. You can see that on table, and very, very important to have a full correction for a CR knee, because it's not going to stretch later on. It will rather become further tight with time. So just to conclude, I will say that preservation is the law of nature, so I would like to preserve the CR, the PCL if possible. However, as a surgeon, you should not be hard and fast. So never and always are not part of your book. You have to be either flexible based on the case-to-case scenario. You can change from CR to PS or medial congruent, or then further increasing the constraint. And thank you all for patient hearing.
So session is open for questions. May I invite all the speakers? So can I start off with one question to you?
Yes.
Yeah. So do you think that a surgeon should be equally adept at CR and PS and mix and match, or do you think one technique suits all?
It's your nature, sir. So as a player, suppose if I tell you, you want to learn the forehand, backhand, front, back, everything. So as a complete surgeon, so I would prefer to have like a more conserving CR surgeon and a PS surgeon and everything. So that's how I moved.
So what percentage of your cases are PS?
So nowadays it's almost 70% of the CR and 30% the PS. The advantage that after converting to CR knees, the periprosthetic fracture of the femur are almost gone in my practice. I hardly see them. And the walking, gait pattern, stair climbing, that has significantly improved in our patients. So that's what I've observed in our patients.
Yeah, I think what Dr. Chatterjee wants to refer is, see, I think you should not be dogmatic. Subhash has, brought out the point. What suits you best, that should be done. I think most of us are trained as PS surgeons, and then we converted to being CR surgeons. And once you become a CR surgeon, most of your practice, your CRs increases. My CR practice are almost 95%. It's hardly 5%, especially with the advent of the, deep dish poly, or the, different people have different names for that. And I think with Indian respect, in scenario, the box and osteoporotic bone and the two holes there, those are the biggest vein. Otherwise, I think there's no difference between CR and PS. They both work very well. CR is a little more, PS is more forgiving. You get better range of motion, and I think it's more forgiving. But if you're not replacing Petla, then CR is much better. That's my
Can
take.
I add? I'm the reverse practitioner, because I started my journey in 90s with a CR, as a CR knee. This is what I was trained in. There were 3 years when I was basically a CR surgeon, but I was forced to do a PS knee because of it was not getting a correction. And those were the time, I'm talking about 2001, 2002, when the knees were bad. And the first time I did PS knee, it made my life very easy. And the result was definitely, the early recovery was no less than a PS knee. So those 3 years gave me thinking, and then the time was around 15 minutes early in a PS knee. The first time I was scared, and still I get scared with the notch. Yes, I do it. That is the only thing which scares me, and sometimes I'm tempted to do a PS knee, because in an orthopedic or the rheumatoid people, and with the osteoporosis, either you try a stem, or yes, you can do a PS knee. So that's true. But I think result-wise, the initial, because I was using LCS knee, and the flexion definitely was much superior in PS knee that time. But now the PS knees are equivalent in range of movement also, they are no less. And but function-wise, I still do not know, because if you look at the papers, they are equivocal. They both have got excellent results. So definitely what Dr. Vijay said, you stick to what you do best. But you should be able to do the other thing also, because a situation may come where you want to do the PS knee, like I said. So you should be capable of doing that also in patient-specific areas or situations.
So a CR surgeon will always be able to do a PSD.
But I get
But-
to always see, I've
but-
done
but-
demonstration of CR knees.
Yeah, but again, you know, conversion, I think this was brought out by him and him also, converting a CR knee intraoperatively to PS knee is also not so easy because, you know, because your flexion cap increases once you cut your your PCL. So then you need to,
That's again scary. That's again
yeah.
scary.
But I think, sir, what you are talking, I think the newer CR implants are much better than they were in early 2000s. Now you have the ability of, you know, just like a LCS, you know, you have a very conforming design. And if you see the results now, you know, the second decade results of CR knees, it is starting to outscore PS. But still they are coming up. So, you know, it cannot be, you know, the final word is not there as yet.
Any kind of conforming insert is actually adding restraint to the beauty of CR knee. And if you look at the
No,
data
so
of
Dilbar-
medial pivots also,
Yeah.
they have a sudden rise in failures from 1% to 3% at 10 to 12 years.
No, what I'm saying is a UC insert not for all cases. I'm saying if required, you can always go from a CR to a UC insert. Now you have that option with you.
But rather
So
than
in
shifting to
yeah, so my practice is if I'm doing anything with the with the PCL, I tend to put a UC insert. And you should know your implant. The Attune, for example, Attune only has one insert internationally for CR. Right? There is no UC insert in Attune. And they claim that it's more conforming and it gives you the function of the same thing. And personally, for me, I've never had to convert a Attune CR to a PS as yet. And we use all systems. It's not like I use only one system. My practice is 10% of everything. And in other systems, there are instances when I had to convert to a PS, but with Attune, never. So you should know what system you are using, what is the capability of your insert.
So I think
Skill
there is
improves with time.
one caveat to that. The worse knees undergo PS and the slightly better ones undergo CR.
Yeah, you are absolutely right. Yeah. So
So I think that explains that slight difference.
I am still to come across a knee that is worse enough that I have to do a PS in a primary.
Well, one last question. You said you will be cutting the tibia along the native slope.
That is very, very important for the PCL to work properly in roll back because we don't know what is the slope of that particular patient. And that is why for last almost 10 years or so, I moved from EM or navigation to IM jig because the first criteria I should have an IM jig to cut a tibia for a CR knee.
but again, Subhash, to that point again, a lot of us have a tibial bowing, tibia, both on the femur side and on the tibial side,
But that's
right? But if you are wholly relying on the intermediate, because it's very difficult to so that is why the intermediary alignment for tibia was never taken up anywhere in the world, just because of this, because it's not that predictable.
So you can double check by using an
Yeah, you
EM
may
as well.
double check, but I don't think, for me, I don't think that is very precise, especially in the Indian population.
I just
practice, I've seen
just wanted to draw your attention that subsidence, incidence of subsidence is low if it is along the native line. Number one. And number two, lastly, I would like to know from the house, is there some joint replacement, anterior cruciate preserving?
Bicruciate preserving was there.
So
but
there is a
it's very
bicruciate
effective.
preserving knee in which they leave an island in between, bicruciate preserving, but I don't think
No,
it
that
took off.
failed actually
Yeah.
miserably in the registry data, so that was withdrawn from the market. I would suggest you try IM jig in spite of the difference in your cases.
The earlier versions of bicruciate knees failed actually because they had a very poor keel. Now recently, I think Smith & Nephew has come up with a knee that has a reasonable flat keel, very similar to triathlon. And this one is doing good in the primary studies.
Thank you.
Thank you very much. I
all
think we had a good
speakers,
discussion.
Chairpersons.
We have to proceed. So we start with next session.
Yes, sir.
So probably the last session of the day. I'll not go to, I've deleted some of the videos, so I'll go straight away to some of the slides. So the deformities could be extra-articular or intra-articular. Mainly we are focusing on intra-articular bone loss, and it could be on the femoral side or the tibial side. Mainly we deal with the femoral side deformities. Okay, and we have to know that we have to release all the osteophytes, assess the deformity, and then release. So assess, release, and assess. Don't go all out releasing the deformity, don't go all out with all your cuts, and then go very sequentially. That is the whole idea about releasing the severe varus knee in bone defects. So knee like these, knee like these are very common, and these are the knees that we get in our day-to-day practice, and we want patient to come up with this kind of knee in follow-ups. And when you release the osteophytes, posterior, medial, lateral, all those osteophytes, you'll end up with this much of cuts and the osteophyte bones all around. So this is what you normally get at the end of the day. Remember one thing, when you have taken all the cuts and you have released, and then you go back in the bone defects, what you will find is that there is still a piece of bone which was hanging there, which you have not taken out. So that is why I said that don't release all the soft tissue, take out all the bones which have already been broken in this severe varus and bone defects, because they're part of the bone which will be there lying somewhere. You have to take it out, and don't release all the soft tissues immediately. That is very important, because once you take this out, suddenly it will become very lax, and then you'll end up what to do now. Excuse me. And then defects like this, there are strategies to plan. You can plan it like you can do a augment. That is one way to manage, but then you need to know is that you need to have a pedestal over which the augment can rest. Okay, if it is a vertical defect, you cannot use an augment. An augment also can be used only in 10 mm, 15 mm defect. And then the sitting of the augment is very important. But the defects like this, which are central and posterior, the CT is not mandatory, but you can see that the defect is central and posterior. And you see the defect like this. You don't take too much of tibia cut. You don't go all out to take all the defect in your tibia cut. You just can't do that. Otherwise, you'll end up in damaging all the collaterals that you have. Okay? You have to build your defect. If it is posterior, you can put screws, you can put bone grafts, and you can downsize your tibial tray. You can remove a bit of the medial side of the bone if you're downsizing your tibial tray, and you get around 5 to 6 degrees of varus correction in that. And whenever you're using a screw, remember you have to bridge, you have to bypass that with a rod. You just cannot use a screw, and you cannot, and without using a rod. So remember using a rod, because I have done all those things and I've failed. So remember using a screw and bypass it with the rod. So just some examples. And defect like this, you can use, there are plenty of bone that is available in your cut. Use your bone judiciously, impact it, screw it, and then put your tibial tray. This will give a long lasting, though initially when you get an X-ray done 6 months time, probably your bone, whatever graft you have done will be gone. Slowly in 1 year, 2 year time, this will reappear again. So that is very important, okay? But then there are scenarios, I'll skip all these slides. Okay, so these are some of the scenarios where the defect is too much. And then you have to use cone or an augment. And then these are cemented cones. And then you have to use rod and cones. These are uncemented sleeves that can be used in defect like this. So, and then you have to use some kind of constrained poly as well, and a constrained implant, TC3 type of construct. So patient like this, which crumbles over their own weight, she completely collapsed, and complete loss of the central part of the tibia we used, and this is around 7 years of follow-up of this patient, and patient did very well. This is just a recent surgery that we did last week, is that we used hinge knee because the defect was too much to handle and it was too much steep. Of course, you can see that the part of the tray is uncovered, but then it is very much centralized at the and the defect is also bypassed. So this is just 1 week follow-up. So decision making, radiology becomes very important. Plan with proper implant, cover with support of the tibial trays of paramount importance. Thank you very much.
Okay, so I just want to ask one question, which is very common situation. You are handling a tibial defect, you have taken the cut. Now, what is the threshold where you can leave that defect filled with only bone and screws. Vis-a-vis, you must use a rod also, because rod means 25,000. Only, or add a rod also, because rod means 25,000. So we're always a little bit worried about the money part.
Sir, if 5 to 8 mm defect and only 10%, 10 to 15% of the tibial tray, if it is uncovered, maximum 20% in the posterior part, then no, probably I'll not use a rod, but otherwise I'll use a rod always.
If it is defect only in the posterolateral or posteromedial,
Less
25%.
than 25%, and if it is more than 5 mm, then I'll use a rod. I'll bypass it with a rod.
So I think a lot of youngsters, and I used to have that inhibition to use a rod just to save money. But whenever you are in doubt, I think threshold, in joint replacement surgery, that's one lesson you must learn: overdo it. Don't think God will help you. God doesn't help you. Okay, so next.
So I will briefly talk about the bone defects in total knee arthroplasties. So bone defects has been classified by based on size by RAND as less than 5 to 10 mm or more than 10 mm, based on location by DOR as central and peripheral, based on margins by INSAL as contained and uncontained defects. So contained or cavitated defect in which the metaphyseal, the cortical rim is, surrounding cortical rim is absolutely intact, it is known as contained. Non-contained defects are in which there is loss of some cortical discontinuity and loss of some segment. It has been classified by AORI, Ing et al. As type 1, in which there is intact metaphyseal bone and defect is contained as type 1, which is F1 and T1, describing femur and tibia, and type 2 and type 3. In type 2, either one condyle is damaged or both the condyles are damaged, then it becomes 2B, and if there is significant metaphyseal erosion, then it is type 3. So what to address in bone defect is it is to restoration of longitudinal, angular and rotational stability. Restoration of joint line is very important. Restoration of soft tissue stability and reconstitution of bone. So how to make good bone cuts? First assess the bony defects prior to making bone cuts. Measure the defects after you have taken your bone cuts. Take great care in removing components, especially components which are very solidly integrated. Beware of always trying to resect the defect because once you go down below the joint line, 2 centimeter below the tibial plateau, the strength of bone decreases by 33%. So keep the tibial cut above the head of and always keep the tibial cut above the head of fibula. So what are the options? Cement and screws, bone grafts. You can use modular wedges, block augments, porous metal metaphyseal cones and sleeves. So implant selection depends on the integrity of the collateral ligaments and extensor mechanism, degree of bone loss, integrity of residual bone. Which implant has to be used? It has to be decided during the surgery. So you should be having all kinds of constrained, semi-constrained and hinge implants in patients who are having severe bone defects. Cement and alone can be used if the defect is less than 5 millimeter, 5 to 10 millimeter. You have to cement with the screw, and screw just act as a support to the cement, and they should never touch the base plate. So why should not we use more than 10 millimeter of cement? Because it leads to thermal necrosis, and a big chunk of cement also shrinks during the setting of the cement. So filling, this is an example of filling with cement. This patient has a loosening of the implant. So implant were removed. The medial side was having a contained kind of a defect. So cement was filled in and screw was put in to hold the cement. And this is the final result. So when to do bone graft, either autogenous, allogenic, impaction or structural. The technique of bone grafting is to convert a concave regular defect to a flat one and bone graft it. So the technique is to expose the bleeding bone nicely, precise fitting of the graft into the defect, rigid fixation with screws and wires, and component coverage of the graft. So this is a case in severe varus deformity. Having severe varus deformity, the medial condyle is totally gone. It has subluxated posterior-medially. So what we have done is, this is the defect size. So on the left, see, we have put a graft there just below the plate, and we have fixed it with 2 screws. Graft is stable. And this is the final result in bilateral. We have done it in a single sitting. Another case, what to do, more tibial resection or downsize and dildize tibial tray or bone on cement or bone grafting. So my plan was to just see the amount of defect there. So we took a conventional tibial cut, made a trial. There was a big defect. Defect measures more than 10 millimeter. We put 2 screws, a graft, and then we put mosserized graft under it, and then we protected both the graft with the mesh, and then we put our implant and covered the mesh with cement. This is the functional result after 2 months. This is the final 2 months post-op X-ray. Wedges and blocks can be used. Augments can be used. Case 3, this on the left side, that implant has become loosened, and on the right, revision surgery has been done elsewhere already. So what we did, we took out the implant. There was a big defect there. This augment should not be used for more than 15 millimeter defects, but we have used this augment for 25 millimeter, and then stabilized it with this. Another case, revision case in bilateral infected revision, and stabilized with absolutely fantastic joint line. Metaphyseal fixation, sleeve and cones has already been told and demonstrated by others. Thank you.
Thank you, Dr. Tiwari. I think we have one more lecture, then we can talk about bone defects. And Dr. Sanjeev Jain is going to talk about bone loss and revision decay. After that, we'll have some 5-6 questions on how do you manage bone defects. I think that will be a very comprehensive discussion.